Well, good morning. We're going to go ahead and get started. First, would like to thank you for attending. We're excited to present the first in what we plan to be a series of webinars, bringing industry experts online to talk about challenges in healthcare construction. I'm Tom Gant. I'm with FreightTrain. We're a software company that provides a solution that enables our clients to help track and coordinate medical equipment, furniture, and IT products during the initial outfitting of a healthcare facility. So today we're going to talk about some of the common healthcare construction budgeting challenges and offer ways to help avoid those challenges. Before we jump in, just a couple housekeeping notes. There is a chat available to you, and so any questions that you have, please enter them into the chat. We're going to discuss 4 different scenarios during the panel discussion. And what we'd like to do is take questions at the end of each of those scenarios. So feel free to enter any questions you have during the chat, and we will get to all of them that we can. If it turns out there's more questions than we can answer in the time that we have, we will find a way to follow up with you. Okay, well, let's start by introducing the panel. Starting with Corey. Corey, would you like to give an introduction?
Yeah, good morning. My name is Corey Gardy. I'm a principal with IMEG, and I lead up our Healthcare Information Technology Advisory Services team. I've been in the industry for about 25, 26 years. My core passion and focus is to embrace technology to impact patient and the care team experience in aligning that early on into the construction design process.
Thank you, Corey. John?
Good morning, John Stiles with the Ohio State University Wexner Medical Center. I'm a registered architect here in the state of Ohio. I've been in the industry for about 24 years, most of those working in healthcare and on healthcare projects. I worked in an architecture firm for about 10 years, and then I've been 14 years here at Ohio State, director of space planning for the medical center. And
John did mention before the call that he's happy to elaborate on the national championship game if anyone wants to do that. And I know Liz does not want to do that, but Liz?
Hi, my name is Liz Callahan. I work at City of Hope as the Executive Director of Support Operations and Planning. One aspect of my scope is activation and transition strategy, which is an area I've been in since post-grad school. I've been in healthcare basically my entire career. And look forward to jumping on into this presentation, Tom.
Thanks, Liz. One thing that I'm excited about with this panel, besides just the expertise that all 3 of you bring, is that everyone sort of worked as on the owner side and as a consultant. And so you have sort of both perspectives to offer to our audience, which I think is super valuable. As I said, I'm Tom Gant. I'm with FreightTrain. We're happy to have been able to organize and bring this panel to you. So we'll start with Liz.
So opening a new healthcare facility is very similar to moving into a new house. So I'm going to walk you through this house and talk about some of the ways that maybe you're going to need to extend the budget that you had planned. So let's look at that red box, the front door. Right when you get there, you realize, because you're carrying in your moving boxes, that it actually opens the opposite direction you thought. And so for the rest of the time in this house, whether you're bringing in groceries or carrying your kids, you're going to have difficulty getting in that door. So you decide you probably want to flip those hinges. When we move over to the kitchen, we realize when we turn on the kitchen sink that water gets all over the counters and splashes everywhere because it isn't regulated correctly. So we want to get that fixed because we don't need a mess every time we wash our hands. When we move outside to the right there, we see that we brought our old outside patio furniture, but there was some existing that now none of it matches. And we really don't like the look of that aesthetic. And I'm sure the homeowners association is going to get on our case. So we want to get that fixed. When we move upstairs, we see that we have those 4 pictures. We had a commissioned piece of artwork that we had ready, but because the artist had a disagreement with the manufacturer, it's not done yet. So now we have to figure out how to get this place decorated before our in-laws come and judge us for not decorating our walls. When we get upstairs to the left there, we have this nice, wonderful reading room set up, but because our aunt wants to move in with us, we now need to make this a bedroom immediately. So we need to move all that out and get all new equipment and furniture in there. In that middle room, we did a very poor job planning for our storage. So we had to come up with some unique alternatives and get that fixed so that we could fit all of our items in. And then moving to the right in the bedroom, you see that we designed with this really nice lighting fixture. However, the only way to clean that and do the high dusting gets dust all over the rest of the furniture, meaning that we have to clean the whole room every time we just want to change a light bulb or clean the lights. And then we move down to the bottom left. You see that we have our mud room, and we realized that there's really no security there. We didn't put in a camera. We don't have an alarm system. It made us kind of nervous. So we decided we should get a dog, which was also not budgeted for and changed our lives completely. So you can see that moving into a house, little things here and there really add up, and they can really impact the budget that you went into it when you were planning.
Thanks, Liz. So the first scenario we're going to talk about is a new outpatient facility that's being built in California. It's about a $400 million project. You can see some of the details about what's going to make up the building. I think a couple things to note is CDs are complete and bids are in for the project, but the bids don't include any operational expenses for the project, and they only include structural needs for IT. So Liz, when we think about the difference between operational expenses and capital expenses, what are some examples of operational expenses that often get overlooked?
So this is a list that could go on and on, but sometimes when we're just focused on the construction, some of the just really easy things about stocking the building get overlooked. And when you're stocking an 8-story building with even things like paper towels, these are going to add up. And so that stock of the startup supplies is a big one that oftentimes the line item's not quite large enough. Other things that happen with OpEx is as soon as that building is ready to have occupants prep it for go live, you're going to need security in there because you need to make sure that the building's locked down. And that is another one that oftentimes isn't allocated within the budget because it's really not something people think about after post-construction. You also get into situations where you have equipment that is below the CapEx line, depending on your organization. I think we're going to get into that later. But lots of little tiny supplies and movable equipment that's going to pop up here and there that just wasn't planned for because either technologies change, workflows have changed, or the workflow isn't going to work the way that was anticipated in design.
Got it. So you alluded to, but maybe expand on sort of the distinction between CapEx and OpEx, and do all institutions view it the same way?
Yeah, thanks, Tom. So in my experience, all institutions do not view it the same way, and that can be very difficult because you have some of the contractors and other firms coming in that are working with multiple institutions, and so they don't know exactly what your organization does. So that's a very important conversation to have up front. Is the threshold $5,000 and 5 years of functionality, or is it different? Because that can go into the original planning if they know that your accounting does not let you bucket every, let's say, trash can together and say that's way over $5,000 worth of trash cans, but we're going to count them as individual items. So now it's OpEx instead of hitting that threshold of $5,000. So that upfront conversation is super important to make sure that everybody's on the same page, and then that budgeting can be allocated correctly across CapEx and OpEx for all the supplies and equipment necessary.
Got it. No, that makes sense. John, these projects have a long life, right? From the sort of initial programming to design to construction to activation. And, it's not unusual that leadership changes occur during that process. How do you manage sort of the expectations of the leaders who weren't involved in the initial design when they want changes and that sort of thing?
Yeah, that's a great question, Tom. I'm going to answer it in two different ways because there's really two levels of leadership. You have your C-suite leadership, CEO, CFO, COO, medical director, those folks. And then you have your departmental leadership, and that can include administrators, nursing leaders, things like that. And the current project I'm working on, I've pretty much had a complete turnover in both of those areas. Multiple departments have turned over, and sometimes even twice. So it gets really tricky to manage as new folks come on. But at the C-suite level, I think the key there is, what do they want to know? They want to know the background on the project. What are the strategic objectives that are being met with this project? What's the program? And probably then the three biggest questions they have: are we on budget? Are we on schedule? And then what are the risks related to the project to completion? And so, just having good data, good information to share with them, a project overview, and then especially on budget and schedule and risk, that's going to make them feel pretty good about the project team, the project, it's in a good place, et cetera. The department level, that's a little harder to manage because those folks come in, they're new, they're more at the room level. They're wanting to see the arrangement of the rooms and why is this here, why is that there, and wanting to, and you can give them that same background, but depending on personalities and points of view, and even how they want to run the nursing in their department, they may want to move things around. And so that's the harder part. And so some ways to mitigate that, in our current project, starting in design development, we started really mapping operational flows, recognizing that some of the folks we were working with in the design may not be there at the end. And so we need to have that operational manual to hand over to those folks and say, this is how it was designed to work. Looking at all the 8 different flows within healthcare, whether that's patients, family, medications, IT, et cetera, supplies, get all of that mapped out and documented. And so as each new department leader comes on board, you have that information, you can review it with them. Hopefully they have staff there that were there as part of the design, and you can get them comfortable. The second way to mitigate that too is then have a very robust user change request process. If they still feel like there's changes needed, having a really good committee, really good process to document why they think the change is needed, making sure leaders of that department are putting in those requests and are aware of them, documenting what the need is, the cost, is it related to patient care, safety issue, is it a nice to have, is it a building flaw, all those kind of things, and then having a committee of leadership that can vet those requests, dig into them further if needed, and then provide answers. But usually the answer needs to be no to keep the project on task, on budget, on schedule. But there are certain situations where, okay, that is a flaw. We need to get that fixed. It's a patient safety issue. But again, that department level side is the harder one to manage of the two.
Yeah, gotcha. Thanks so much. So
just one thing to tag onto that,
yep.
Tom, if that's okay.
Yep, sure.
Totally spot on, John, with those 2 mitigations. And the user change request, a really important aspect of that is that you have a governance process in place, and that the executives draw a line in the sand and say, we are not doing any user change requests past this date unless it is a safety or regulatory issue. And then super important when those new executives come on board to get in front of them fast, get them up, everything that John said, get them up to speed on the project so that they know all that historical background and don't start probing too hard into like, well, why is the IR on the 6th floor? And they want to move it to the 4th floor, right?
Yeah.
Like some of these things that would be such major handicaps for the project.
No, that's great. That's great. So in this scenario, it says bids only include structural needs for IT. Kind of makes sense. That feels like that's what happens during construction. But Corey, that can present some challenges, right?
Yeah, I mean, I think historically, and I'm sure probably most of the folks on the call have dealt with this, is IT is usually kind of an afterthought. And what we've seen and continue to see, unfortunately, is that, early on in the process, when they talk about technology, it is kind of the low voltage side. It's kind of the closet sizes, the cable pathways, maybe the port counts, servers, things that we kind of see today as somewhat of a utility. In reality, technology is playing a significant role across the board. And if you don't have the proper forethought to have the teams engaged from the very beginning, frankly, you're going to miss the future of where healthcare is going. We are all patients on this call, I hope. And, our role is to really help support and embrace kind of where things are going. And you have to take a look at how technology is impacting it from the time the patient or care team members are at home until the time they come home. And there's a lot of things that go into it. Yes, there is these big EMR vendors like Epic that it's really one application, to be honest with you. That picture on the left-hand side was a project. It was a 250,000 square foot children's hospital. And that's all that they viewed as technology. where reality on the right is, potentially 75 projects across the board that, touch everything from clinical communications to patient experience in the smart patient room, all the way down to the infrastructure. I can't, overemphasize the importance there, but, really taking a holistic lens of the application side, the infrastructure, departmental specifics. We can't view these technologies as silos anymore. Cybersecurity plays a role into it, and we need to be treating these buildings as really living and breathing entities, just as the people that interoperate. And if you don't take into consideration the impacts that it can have in designs or budgets, that lovely term called value engineering comes to play. And really, we need to be evaluating target value design of what clinical operational quality outcomes can be achieved, leveraging technology and embracing, the design and the future of patient care. So, we try to really encourage, and I'm sure Liz and John appreciate this too as well, is that, technology needs to have a seat at the table just as interiors. It might not be a driving role, but it really needs to play an impactful role. And having that holistic lens is kind of where the FreightTrain environment comes to play, is that, we can kind of see room by room of what the technology needs to play.
Awesome. Yeah. Perfect. Thanks. Any other comments from Liz or John?
Yeah, I'd say real quick, Tom, I don't think you can understate how embedded IT is in just all systems across the hospital anymore. I kind of joked with Corey, and I joke with our internal IT department, but it really feels like we're a IT organization that just happens to do healthcare. It's just saturated throughout all the different systems. And to Corey's point, they need to be there at the table from day one, planning that, or else you're going to get into a situation where you can't support visions that leadership has for the building.
Well, and John, in our conversations even past, is simple things like rooms, room numbering, or room labeling. It seems very trivial. Construction has their own monikers and values, but what is displayed and impacted in Epic, if you're not thinking about that and the impact that it has, I mean, the cost could be easy 6 to 7 figures of an impact to a budget. And I don't know, John, if you want to reference your story on that, but I think it's a pretty good story on it.
Yeah. Well, yeah, I'll keep it short because I'm sure we're burning through our time here. But we built a tower in 2014 where we can only, and some of our systems support 4 numerical digits for a room number. So we had to repeat room numbers and add letters based on the floor plate size. And when we added a large tower to that building, we could support 5 numerical digits. And so we're like, hey, we got to go back and then renumber those rooms in our IHIS system. Through discussions, came to realize we weren't really changing a whole lot in terms of physical signage or anything, but just with the amount of labor involved and the number of systems that it touches, it was a $500,000 hit to the budget that wasn't budgeted anywhere.
Yeah, that's phenomenal. And to the theme of this presentation, that's one of those surprise kind of situations. Okay, any questions from the group in what we've covered so far in this scenario? I think we have any in the chat.
There is no questions on the chat.
Okay, perfect. And to the audience, please feel free to add questions if you have them. But we'll move on then. So sort of the next scenario, Corey mentioned value engineering. So in this scenario, we made some decisions to reduce cost during the design that can significantly impact the long-term financial health. And so if you're faced with the situation where you're going to have to make some, difficult cost reduction decisions, how do you do that while still preserving sort of the integrity of the project? So John, in your experience, what drives the need for value engineering in the first place?
Yeah, I think the assumption is somebody messed up, either they didn't get the scope right or they budgeted too little. Oftentimes, I think most of the time that's not the case. It can be true, but likely it was something wasn't communicated well, or something that was originally thought to be easier to accomplish is now much more complex. And so I also think there's a lot of unforeseen conditions that play into the need to perhaps adjust budget. Again, we talked about leadership change. They can bring change to the project, change to scope. Obviously, that would drive the need to revisit budget. Market conditions can change quickly. I think we all went through 2020 and remember what happened there. Just these large healthcare projects are so complex, and I think we need to try and have as many right answers as possible, but recognize we're going to be wrong in some areas and have that flexibility built into the project, into the budget, that we're going to have to adjust in some areas. And sometimes it's just misalignment of vision. So maybe the project budgeted a temporary walkway to get patients into a hospital while something's under construction, and they just anticipated, hey, it's just going to be some scaffolding and a hard lid of wood. And then leadership comes back and says, well, we want, walls with windows and lighting and security cameras and benches. And, oh, by the way, we want to put up great graphics in there. And, it needs to meet ADA and all these different things. And those are all great things. And it's a great vision, but that's not what's in your budget. So, trying to find as many of those things up front as possible, making sure there's alignment. That's where it can get difficult. And I think Corey started to mention it. I mean, there's a lot of ways to try and avoid value engineering out there. Integrated project design, target value design, satisfaction by choice. I go the old-fashioned way. I think communication and coordination amongst the team is so important to avoid a lot of that. And then if you get in that situation, again, coordination and communication to resolve the situation before taking your resolutions up to leadership.
Got it. So Liz, what are some examples in your experience of, cost-saving efforts that led to negative outcomes and, ultimately cost more in the long run?
Yeah, I mean, unfortunately, I have several examples of this. And one of the things that John said that I just want to tag on to before I get into some of those is the fact that people are misaligned on their goals as well. So you have a general contractor who is shooting to hit a certain timeline, hit the budget, because they get incentives to do that. Whereas you have operations team who wants the best of the best for the patients. It's not to say that the contractor doesn't want that, but the goals are just misaligned. And so if you don't have that coordination and leadership being brought with both perspectives to make the decision of, well, should we cut this or should we spend extra money to have this other opportunity, then you're going to find yourself in the situation that I witnessed at a hotel opening on a healthcare campus, where they took out all of the patient assist bars next to the toilets to help someone stand up and sit down. And immediately nursing raised their hand and said, this is a patient safety issue. Now, this is a hotel, so it's not a healthcare space. So there actually isn't a regulation stating you have to have those in the hotel. But we ended up having to put those in, and we had to do that last minute. So it had to happen after a clean occurred, which meant we then had to re-clean the entire building due to the dust created by the install. As well as this was actually during the 2020. So the shipping on that was extremely difficult to get them in time. It almost pushed the go live of the hotel, which causes more, as you can imagine, downstream costs. Another example I have, and this one just makes me chuckle because it's far enough in the past, but I opened up a medical office building and it didn't have any coat hooks for the physicians' coats. And there was basically an uprising. And they said, we're not going to work in these offices until we have somewhere to put our coats. So the night before go live, I was there with the activation team, a bunch of the facilities folks, literally drilling coat hooks into the wall, taking a vacuum right behind us and cleaning up and making sure that we were ready for that. Now, the cost of that wasn't that great, but if you consider the labor and the effort that had to go in at the 11th hour, it's not good optics on the project. And there's been bigger ones. So in a case where an HVAC system, they did a little value engineering to try and do more with less. And it ended up that a print shop had the thermostat in it and not the big kind of cubicle farm. And so the print shop would start printing and it would heat up. And so then it would start to cool off everything in there. But that was basically freezing out the entire cube farm. And so they ended up having to redo an HVAC system that was already above ceiling. And I can't imagine the cost on that one. But it did delay operations. We had to move all those folks to temporary offices because they were the research nurses. And it was a big impact to the organization.
Wow. Yeah, that's significant. So, Corey, you alluded to it, and John sort of chimed in. But if the situation occurs, regardless of why, that we have to make some of these cost reductions, how's the best way to do it while avoiding the scenarios that Liz described, and who should be involved in those decisions?
Yeah, I mean, as it pertains to technology in general, I mean, you ultimately need to go back to the clinical and operation areas and departments that's going to have an impact on. Their voice is critical. I mean, IT, I think John says, is that we are an enabler, but we are not the solution. And to have that voice and understanding clearly what the impact, if we don't do X, what does that mean on Y, early on in the process, and if there's any mitigation strategies that can be accomplished. Like John and Liz, I mean, they've made significant investments in IT, and like probably a lot of you on the phone, is that, maybe there is current solutions in-house. So there goes back to maximizing, current investments, and it doesn't necessarily need to be a net new, but collaborating communication, as John said, is absolutely critical. Understanding all facets, what the budget impact it has, potentially what the design impact it has, and then coming to that hard decision: can it be done, or do we need to delay because it's going to have a significant impact on the activation or the processes? So there really isn't a great answer, but I think that having these strategies and teams in place early on can help mitigate that. But I think it's getting the right people at the table and really discussing all facets of the impact and what it can be, how it can be resolved.
Got it. And John,
Hey, Tom,
I think you
if I
had
could
some.
add on to that.
Yeah.
I think where we found ourselves getting in trouble is when we don't have those subject matter experts in the room to help make those decisions, and somebody else is making it. And we, on a project, we had a suction piping issue. Administrators decided to eliminate the suction piping to a couple of floors. We really need to have that, and so we had to come back after the hospital was open and put that back in. We had to close down patient rooms. I mean, it was. We spent way more money fixing the problem than any cost savings that we got out of that. And there's been other examples of that, but I think there's sometimes some concern that if we involve those subject matter experts or the end users that Corey was talking about, they're going to be latched on too much to those ideas. And I can't give that up. I can't give that up. But I think if you make them a partner in the process and say, this is the amount of money we need to get out of the project, and these are the areas we're looking at doing that. So what are your areas that we really shouldn't touch? That's just going to be too detrimental. And then some areas that we can touch and perhaps reduce maybe the design a little bit in those areas. I'm thinking about engineering as well on the current project I'm on, and we involve them throughout to make some of those hard decisions. You also have to think through the life cycle costs and the ongoing operation and maintenance costs of those decisions to see, okay, is this short-term savings, whether it's a couple $100,000, could be a couple million, is that worth it in the long term, or costs down the road going to dwarf any savings that we have today? And it's just not a good decision.
Yeah, and just to also build on that too there, Tom, is that John had a good point, is that it's okay to ask your engineers or your consultants or partners in this game. Realize you're not alone. There might be some unique cases where it's the first of a kind type of issue, but be open to saying, how is John doing it over at OSU, or Liz, utilizing it at her organization? Don't be hesitant to reach out and understand and really engage your engineering partners or your consultants on the project, your activation teams, to see how other organizations potentially challenge this and resolve it.
And so last point, Tom. So in terms of maybe some of the ways to do it the right way, or processes to do it the right way. I know a lot of folks use the A3 format potentially, and that's a great format to document decisions. It can be a little bit process intensive. Another really good format is the SBAR process. So identifying the situation, the background, the assessment, the recommendation. It's a little less process heavy, a little more reliant on your subject matter experts, your team, to put that information together. And then ultimately, that's the key, right? You have to put the information together, take it up to leadership, and then leadership gets to make the decision. and we're going to live with that, and we'll move on. But yeah, as Corey said, it's getting the right people in the room, documenting it properly, and then moving it up to the right decision makers.
Got it. Perfect. Okay.
So
thanks.
we have two questions on the chat. Sorry. First question is it typical for healthcare organizations to only track budget on external purchases and resources versus any sort of time, personnel of any internal resources needed?
That's a really good question. And the next scenario, we'll probably get into that a little more. But Liz, do you want to take a shot at that one?
Yeah, that's a wonderful question. Thank you. And going back to the original thought of what is missed in OpEx, this is absolutely part of it. So organizations do it a little bit differently. My best practice is that you build into the activation budget the time, the labor that's going to be required to activate and train on that building. Because if you don't, you're asking departments to absorb both perhaps new employees that they're not going to be budgeted for most likely in that year, and overtime that their teams are having to do to set up that new facility. So different organizations do it differently. But like I said, I use a calculator that I've developed over the years that puts in the size of the building, what specialties are in there, and how many super users we're going to have, how much training is required. And then it kind of spits out the number of hours that it'll take. That's been very beneficial. You have to really, if you're going to do that, get very specific about the why you need to be paying for all this labor out of a different budget. I like to use the rationale that it's very important to track the actual project costs so that when in the future you're taking a project to the board, it's not just the construction cost. Again, remember that's mostly going to be capital, and they're going to approve that $10 million of capital. But what they're forgetting is there's another $5 million of OpEx that's required. And so now it's a push to try and get that building open adequately, and a lot of do more with less.
Yeah.
Thank you.
Thanks,
And the second question is, how do you manage when you have too many clients, subject matter experts involved on a project?
So John, do you want to take a shot? I mean, you were encouraging getting SMEs involved, but maybe there's a point where you could have too many?
Yeah, I think I think there's definitely a tiering within your subject matter experts. So usually you should have a point person or two in each area. Who's my go-to person or persons in IT, or the engineering disciplines, or I know in our case, then working with the departments and the end users, a lot of times we have administrators we can work with. And they can either go take that to their teams and get information to feed back to you. It's definitely a risk to getting 100 folks in a room to make a decision. It's the wrong approach. It needs to be a small group, but I think that's where your governance structure comes into play, really knowing that who are your leads, having them identified, and then leveraging them in these kind of decision-making processes.
Got it. Thank you. Okay, let's move to the next scenario. And I know that I think the slides, there's a little delay, but they will come. So this situation is you're building a new inpatient tower. Early in the design process, there was discussions with leadership about kind of what Liz brought up is, there's a budget necessary for the transition and activation planning. We basically, kick the can down the road. Now you're getting closer, and you got to start that up again, potentially with new leadership. So how do you, convince leaders that there really is a need for this, and it's not a nice to have? So John, I know that's sort of near and dear to your heart right now. Do you want to take a stab at, how to think about that?
Sure. And what Liz said about documenting it project to project is so important. Because I think a lot of times maybe you figure it out on a project and you have a great activation process, and then those people and those processes get lost in folders on the network drive somewhere, or they move on to different parts of the organization or even other organizations. And so the more you can get that documented and written down and have standardized, repeatable processes, the better shape you'll be. But a lot of times new leadership comes on, says, oh, and you come to them and say, hey, we need to get activation going. And their first question is going to be, well, what's in the budget? And you may have to say, well, we don't have anything in the budget because previous leadership cut it out and said, we'll deal with it later. And that's always a little bit of an awkward conversation. And it's going to sound really basic, but you just have to spend the time to build a really solid plan. And that's not an easy thing to do. It's lots of discussions with all the different departments that are going to be moving over to this building, and what are they going to need on between construction being done and the building going live to make that happen. And you may be dealing with some very veteran people within the organization that know if I ask for 4, I'm really going to get 2. And so they're all going to over ask, and you have to weed out the actual needs from the wants. But it can cover a whole host of areas, whether that's paying for security on an interim basis, or cleaning, or utilities, or equipment that was installed early, making sure that's staying in tip-top shape. Starting to stock the building with supplies, all the education and training that will have to happen. And that's time that staff need off to dedicate to those processes. It can just add up quickly, and the number can get very large. So again, you have to build a comprehensive plan. You have to vet it with all the key stakeholders, vet it multiple times, again, getting to a true number there, and then feel confident in your data, take it to leadership. If you've got a great plan, you've got the data to back it up. A lot of times they'll hopefully approve it. You may not get everything, but hopefully you get a majority of what's needed to get that building open.
Right. So I know that there are times when, the C-suite sort of thinks, well, gee, we move equipment a lot, we move patients a lot. What's the big deal? Can our team handle this? So Liz, I mean, when you think about, I think some organizations sort of may take that perspective, others may recognize the need for this. How do you sort of navigate that when you're, kind of trying to address some of the issues John brought up?
Yeah, so I think one of the big things to learn about your leadership is, have they been through a major activation of this type before? And if they haven't, one of the most important things to do is go watch one somewhere else. Yeah. There's really nothing that can show you the magnitude of the effort required than seeing it live. I think individuals who have been through a major activation, it says, obviously we need to do this. And it really helps when you have these conversations about budget. I've also had conversations with folks who thought we could maybe do things internal, and they'd never done an activation. And I likened it to our migration to Epic and a go live of Epic, which was just a huge undergoing. No one thought it was going to be that big. It spiraled because it was obviously a massive project. And the people who were at the organization during that time, it clicked and they got it. And they said, okay, now we see the type of discussions that we need to be having. Because I think a lot of times this is an easy place for them to say, let's cut some costs on this side. And to John's point, when you take that data forward, having some real numbers like the utility costs post TCO that are going to be absorbed by your internal engineering teams as opposed to the construction folks, you can get that number pretty quickly. And that is going to be a big ticket item that you're going to have to carry for however many months until opening from an activation budget, or are you asking facilities to absorb it? Either way, bottom line of the organization, it's going to hit someone's budget. And if we're not capturing these costs back to that point, then you're never going to be able to get everyone aligned from a leadership perspective on what the project's full budget should be.
Makes sense. So, you mentioned, getting consultants to help with the process. In addition to thinking about that, are there, like technology, software tools that you can use to help?
Absolutely. I mean, I've worked on projects across the country, and depending on the size and the scope of the project, you might be using different tools. Back when I first started, Excel was kind of one of the ways we tracked everything. But I quickly started using FitUp actually during my time at Stanford, and found that type of tool that allows you to document everything, kind of a one-stop shop, that you can do your room checks, where the equipment is, you can track these POs. It's going to allow you to simplify your process and get everybody to one source of truth, which is my other advice if you are using technology. whether it's smart sheets or some sort of project management tool, everyone needs to be working from the same list. If you have multiple punch lists out there, if you have multiple task lists, then you're going to have people miss things. And when it comes time for licensing or go live, you're gonna struggle. So absolutely recommend using, especially for something this large, you're gonna need consultants who are experts in this field. Just grabbing a good project manager from your organization and saying, okay, you're gonna activate this. The actual subject matter expertise required for an activation, especially in states difficult like California and some of these areas that have like very difficult regulations. You don't have experts in that, then you might end up failing licensing, missing your go live, and adding just astronomical costs to your project when bringing in those individuals who have that background, utilize that technology and bring that in is such a small cost compared to repercussions from not bringing in the experts and using the best technologies.
Yeah. John or Corey, anything to add to that?
No, I chuckle because I think we've all utilized Excel in some way, shape, or form, and pivot tables and everything. And you know, it's a great tool, but having that, especially from a technology perspective, because I think that, you know, that's one thing, that area that has kind of lacked, in my opinion. And I love Liz's comment about the Epic Go Live. I mean, these efforts, for even if it's a small clinic to a large, multi-story hospital, is very comparable from a change management to an Epic Go Live. And if you don't have the tools to track the devices, just as you're tracking medical equipment on a room-by-room basis, same logic has to apply to technology, and understanding it's not just the computer in the room, it's not just the PC in the room, it's how those interoperate with all the other different systems that might go on the floor, and understanding the workflows that, simple things such as a nurse call button, if you push it and it rings to the console of the desk, great, it works. But if you start thinking the layers in that it might go to a mobile phone, the closest care team member, change, your rapid response team, all the different facets that need to go into that if it's not documented within a centralized tool to understand the functional intent of each of those rooms, it just presents opportunities to fail and really invalidate some of your testing. And then you have a lot of ticked off care team members on day one.
And I just emphasize, that single source of truth. Everybody does Excel in their own ways. So if you can have a single software program that brings it all together and provides great data, because depending on the project size, leadership's going to be very attuned and wanting updates on a regular basis, and you want to be able to provide fact-based data-backed information. And just kind of saying, well, I think my Excel says this. Is it going to be good enough? And another thought real quick too was, I think there's probably some things that the organization can do pretty well. It's a little bit know thyself, and medical organizations, maybe they can do a lot of education and training. But to Liz's point, going out and seeing other institutions and their moves and their processes and just how big it is, super important, because you likely know an organization's done that before. And so then bringing on the right expertise, making sure the team has the right software to work with, it's all key to making sure. I'd say the sooner you can start, the better. Folks are going to question, why are you getting started now? And it certainly depends on the scale of the project, but in some ways, it's that begin with the end in mind, right? The Covey principle. Even from design, you're starting to think about, day one opening and working it backwards, and when do we need to get activation going and get everybody on board and aligned to this new building. So,
yep, no, and that's certainly been the experience with you guys on this project. Okay, so it looks like we do have another question, Diana.
Yes. How do you secure stakeholder and users buy-in for implementing a system like FitUp?
Liz, do you want to take a shot at that?
Yeah. So FitUp, if people haven't used it before, and they have their own, everybody has kind of their own way of managing a project. So what we like to do, it's what John just said, is start early, get it in front of them early, get them comfortable with the manner in which we're going to engage with it, and let them ask questions. I usually take them directly to the source and go right back to the organization, have the training done by FreightTrain, so that if they have questions, if they want to probe on how this technology works, if they want to dig into that at all, the expertise is there to give the rationale. There's always going to be a little bit of time for user acceptance buy-in, and that is just normal to a project. So if you start early and get people comfortable with it, once they are, I only hear compliments of it, and people are grateful that we're using it, because it's much easier to walk around with an iPad and make a couple notes than it is to try and carry my computer around and type into Smartsheets. And people start to see that. And then the other thing about it is, especially from the leadership perspective, the way that you specifically with FitUp can pump out dashboards is super helpful. And you can kind of gear them up or down depending on what level of detail you need. And so when you have executive leadership who's maybe very hands-on, they have that at their fingertips. They can see real time everything that's happening and get the roll-up version of it. And while you can obviously do that with other programs, I found that FitUp is kind of built specifically for this. So you're not having to start and build out a project yourself. It's focused on healthcare organizations and openings.
Thank you. Any other comments?
No.
Okay.
Thank you.
Perfect. Okay, so we've got 12 minutes left. I think that gives us time to wrap up. The last scenario is, and I think it was alluded to, John mentioned market dynamics early on, but obviously we've just been through a scenario where all the best planning in the world wouldn't have prevented a pandemic and some of the issues that came from that. How do you think about hedging against that or building flexibility into the plan? John, any thoughts about that?
Yeah, I think it's it's not necessarily easy to predict, and most of the time inflation's not going to come from pandemic, thankfully. But there's always going to be inflationary pressures. I mean, everything's always cost more in the future. It depends on the market that you're in, the scale of your project. If you have a tight labor market, do you have enough labor to get your project done? What's happening elsewhere in the country? Unfortunately, we've seen some of these natural disasters, the hurricanes in the southeast and the fires out west. That's going to just drive more inflationary pressures on materials and costs. So I think it's just sort of a fact of life, and something we have to recognize that folks aren't going to necessarily like this statement, but I've told a couple other organizations that have called us up and talked to us about projects. Even if they haven't started design yet, they're likely over budget and need to start thinking about ways to reduce and have those things in mind. And it sounds terrible, but it's just kind of a fact of life. You're going to get to that schematic design estimate, and you might be a couple $1 million over. You could be more than that, or maybe you got all the stars aligned, you got everything perfect. But I think just planning for how we're going to deal with cost overages, how we're going to approach it, maybe getting that process set in place initially, that governance structure, who are we going to include, have all that thought through up front, and then that just maybe takes some of the stress out of that process, and again, it gets back to that whole communication, coordination, teaming aspect of the project.
Yeah, no, that's good advice. So I'm curious, the capital programs include, exciting new builds, but there's also a lot of renovation that occurs. Going back to your home scenario, Liz, I know renovation can be almost worse than building a new house. So from a budget surprise perspective, are you sort of more likely to run into challenges in a renovation versus a new build, or are they about the same? Liz, do you have some comment?
I think, a greenfield project is much easier than when you're trying to recreate a new dynamic in an existing facility. I've worked at organizations with very, very old buildings where basically there's one facility individual engineer who's got the as-built in his head, maybe, and we don't have anything. So then the surprises jump out of everywhere. I've run into projects where we were just trying to put out a parking lot and ran into a steam pipe that burst that no one knew was underneath it, which was millions of dollars to repair. So anytime you're on somewhere that just isn't a clean slate, you're going to hit something. And you're also going to be disrupting whatever's happening on that campus. So if you're renovating, even if it's just, the first level of this building, well, we're still trying to have clinics on the second and third. So how do we make sure that the patient experience is not impacted by our renovations, and that we get negative, patient feedback because wayfinding is more difficult, or we messed up their parking and so they're having to come in a different door, and all sorts of things that can add to a patient's day, which is never what an organization in healthcare wants to do. So I think those are much more difficult. I would much prefer to always find a nice empty field somewhere and build on that.
No, that makes sense. So when we were talking about sort of the value engineering and that sort of thing, there was a lot of conversation about getting the right stakeholders in the room. A lot of these, you guys represent large organizations. Decision-making sometimes takes longer than you'd like. Maybe Corey, watching it from the outside as a consultant, do you see that sometimes delays in decision-making can create budget risks?
Oh God, yeah. Well, 1000%. From an outside perspective, we have to appreciate that, Liz and John have a lot of things on their plate. And some of these decisions are very hard to make, but are critical. And I think that this goes back to, again, I think that the message here is the communication, clearly articulating what the impact on this has, what the budget, the design, and really holding them, feet to the fire, so to speak, on some of these things. And sometimes it's not easy. We're consultants and we can be that kind of referee in the room, but I think as long as they understand, and I'm using they as a very broad term here, really understand the impact. You'd be surprised when people get together. I was just in a meeting yesterday at 7 a.m. where we got physicians and clinicians, and because it was the only available time, and we maximized that effort, and everybody understood it. I think the other thing too, from a message from any consultants on it, is be clear and concise. Don't over, complicate things. And I think that there's a lot of intelligent people that understand exactly their operations and business impacts that can make these decisions, in a timely manner. So long-winded answer, but yeah.
Yeah, no, well, thank you. So we're running to the end. So I think we'll start the wrap up. But first of all, Liz, Corey, John, thank you so much for participating in this. And to everyone in the audience, we appreciate you being on the call. I hope you found it valuable. Sort of key takeaways, as John just said pretty eloquently, you will be over budget. So plan for that. And Liz alluded earlier on the importance of complete cost discussions, not overlooking sort of the operational costs that you're going to see. And also it's sometimes easy to overlook activation and transition. And to the question that came in earlier about, external cost versus staff cost, that activation and transition is a big place where you're asking people that have a full-time job to do another full-time job, right? And so you got to be careful about all that and prepare for the surprise. We put together a checklist. Everyone will get a copy of the slides and of the checklist, so you don't need to take a screenshot. But these were just some things to look at as you're thinking about your budget. And in many ways, the cost will be the cost, but it's important to the degree possible to have planned for it. So we're about to wrap up. I've got one more thing, but are there, I guess, no more questions from the audience? We will, as I mentioned before, the FreightTrain team is really thrilled that we have folks that are interested in sharing their expertise with you. And we're planning to do this quarterly. We've got another one planned for April 9th. And this is talking about a comprehensive approach to the planning, purchasing and deployment of medical equipment. Jill Worley-Shook from Northern Arizona and Danielle Maddox from Sarasota Memorial will join Diana Silva in that session again on April 9th. So look forward to that, and we will certainly, send information out about that. But in closing, thank you again, and the speakers have all agreed that if anyone has questions that you didn't ask on the session, or if something occurs to you later, that they're more than happy to respond to an email question. So with that, I think we're done. Thank you again to the panelists and to the audience. Have a great day.
Thank you all.
Thanks.
Thank you.